Welcome to the launch of Australia's first national standard for psychotropic medicines in cognitive disability or impairment. I'm your host, Tegan Taylor, a journalist and broadcaster, and it is my pleasure to be here today. I'm hosting this webcast from the lands of the Gadigal people, and I'd like to acknowledge the traditional custodians of the various lands from which you are all joining us today, and pay my respects to all Aboriginal and Torres Strait Islander people participating in the webcast. Over the past 30 years, there's been a 60% increase in the number of psychotropic medicines dispensed in Australia as a whole. That includes antipsychotics, antidepressants, and sedative hypnotics. Today, we're focusing on the use of these medicines in people with cognitive disability or impairment across the lifespan. We'll be hearing from experts in aged care and disability medicine and people with lived experience as we discuss what the standard means for clinicians and health services and how it will benefit people and their families. But first, it is my pleasure to introduce the Honourable Ged Kearney, Assistant Minister for Health and Aged Care.
I'd like to start by acknowledging the traditional owners of the lands on which I'm recording this, the Wurundjeri people of the Kulin Nations, and I pay my respects to elders past and present. I also want to thank Tegan Taylor for facilitating and acknowledge each of the esteemed panellists joining you today. Conjoint Associate Professor Carolyn Hullick, Professor Julian Treloar, Professor Edward Strivens, Affiliate Associate Professor Juanita Breen. The findings of the Royal Commission into Aged Care Quality and Safety and the Royal Commission into Violence, Abuse, Neglect and Exploitation of People with Disability unearthed some truly disturbing practices and standards in the Australian health system. For many, the findings were as shocking and surprising as they were saddening. But for others, those who had suffered and their loved ones, it was a watershed moment, one where years of advocacy and calling for change was now possible. One particularly upsetting discovery was the overuse of psychotropic medicines being used to restrain vulnerable Australians. Older Australians and people with a disability, people who need to be looked after. Now, there is a role for psychotropic drugs in healthcare, but across the board, psychotropic medicines are overprescribed and overused. They're being used to soothe, sedate, and influence people into care who are exhibiting concerning behaviour. There's little evidence that psychotropic medicines are effective in managing behaviours of concern in people with cognitive disability or impairment. In fact, there's evidence that suggests the opposite. Non-medication strategies are the best way to prevent and address behaviours of concern. And psychotropic medicines are a high-risk medication that should be a last resort. It's why it's time for more rigid standards to protect the health of our most vulnerable Australians. And it's why it's an honour to be launching the new Psychotropic Medicines in Cognitive Disability or Impairment Clinical Care Standard. Professor Duggan and her team have worked so hard on these new standards, and I congratulate you for the work you've done. It's going to make a big difference. A new gold standard that will be enforced to protect Australians. A standard based around managing the risks associated with psychotropic medicines, around supporting carers with diagnoses, improving behavioural support planning, and promoting preventative and de-escalation strategies. A standard that will strengthen provider understanding of informed consent and the appropriate administration and monitoring of psychotropic medicines. A standard that will improve the healthcare system because we are constantly striving for a system that protects Australians, particularly those who are vulnerable. And that's why we all do what we do, right? This standard is only possible because of the hard work across federal, state and territory health bodies, clinical experts, the private health sector and the valuable guidance of patients and their carers. So I want to thank all of you there today who are involved with this work. You are improving the lives of so many people, and that is no mean feat. Congratulations and thank you.
Thank you, Minister, and thank you to everyone who is joining us today from around Australia, and especially those who have submitted questions, which have been very helpful in planning today's event. We're going to get to the panel discussion in a moment, but before we do, let's learn more about the standard.
Introduction to the Psychotropic Medicines in Cognitive Disability or Impairment Clinical Care Standard. People living with cognitive disability or impairment are valuable members of our community. They include older people living with dementia and people with neurodevelopmental disorders like intellectual disability or autism. Psychotropic medicines are often prescribed to these groups of people, either for mental health conditions or for behaviours of concern, also known as challenging or changed behaviours, including aggression, agitation, and sometimes self-harm. When medicines are prescribed for the main purpose of influencing or controlling a person's behaviour, this is a restrictive practice for which there are safeguards in place. Psychotropic medicines have a role to play in the care of many people, and prescribing may be very appropriate. However, research evidence and 2 royal commissions have shown that these medicines are widely used in older people and people with disability, often without informed consent, for prolonged periods of time and without appropriate monitoring for effectiveness and adverse effects. The standard aims to improve care for people who have a cognitive disability or impairment whenever and wherever they receive healthcare. It focuses on 8 priority areas where improvements will help to reduce and potentially eliminate the inappropriate use of psychotropic medicines in these particularly at-risk populations. 3 elements of the standard apply when a person has behaviours of concern. Firstly, the standard says to identify possible causes of the behaviour through comprehensive assessment. Don't assume the issue is due to the person's impairment. Next, always use non-medication strategies as the primary method for preventing and addressing behaviours of concern, even when medicines are considered appropriate. And thirdly, use a well-developed behaviour support plan to guide management and refer to the person's plan if you have not seen them before. The remaining elements of the standard apply whenever psychotropic medicines are being prescribed for any person with cognitive disability or impairment, regardless of the reason. Importantly, support informed consent. Discuss the risks and benefits of the medicine in a way that the person and other decision makers can understand. Use medicines only when there is a clear reason and document this for other healthcare providers. Monitor and review medicines regularly to check for side effects and to make sure they are working as intended. Where there is no benefit, stop the medicines. It is essential that the person's preferences, needs and values are considered at all times. And as healthcare workers, we make sure that information about the person's care plan, including any psychotropic medicines, are shared effectively at transitions of care. Working together, we can improve the health and well-being of people with cognitive disability or impairment and reduce the use of these high-risk medicines. This standard is endorsed by the Aged Care Quality and Safety Commission and the NDIS Quality and Safeguards Commission, as well as more than 20 professional organisations and peak bodies. You can learn more about the standard and the supporting resources on our website.
So with that short introduction to the standard, I'd now like to introduce our expert panel, Conjoint Associate Professor Carolyn Hullick, who's Chief Medical Officer at the Australian Commission on Safety and Quality in Healthcare, Affiliate Associate Professor Juanita Breen, a credentialed pharmacist and aged care researcher specialising in dementia research at the University of Tasmania, Professor Eddie Strivens, geriatrician and clinical director at the Cairns and Hinterland Hospital and Health Service, and Professor Julian Troller, neuropsychiatrist and the director, the National Centre of Excellence in Intellectual Disability Health at the University of New South Wales. And Carolyn, I might start with you about why the Commission chose to have the standard scope extend to both the aged care and disability sectors.
I think it's actually one of the most important and complex things that we've done at the Commission. I think we had 2 royal commissions, both in disability and aged care, and a really strong message was around the use of psychotropic medicines and that we needed to do better. So the Commission was keen to bring both the Disability Commission and the Aged Care Commission together so that we could actually talk about psychotropics together, because without the 3 sectors involved, it's going to be very hard to look at the problem. And I think that we I think that from my perspective, I was really keen that we thought about it from the person's perspective. So some people with disability live in aged care, and a lot of people with disability and older people do come to the emergency department and hospital. So we were keen to look at what were the safety principles that we needed to address and make sure that wherever a person was across the community, that we were actually thinking the same ways about medicines.
Yeah, because Julian, people aren't just one thing. How do we handle this dual diagnosis situation?
Tegan, I think the intersection between mental health, cognitive disability and behaviour is really quite a complex one. And we know that people living with cognitive disability experience very high rates of both mental health and behaviours of concern. And so when you think about what we're doing in this space as people who are prescribing medications, we need to think very carefully. And this clinical care standard is all about equipping both people with disability and families to understand and have appropriate expectations around prescribing, equipping clinicians with skills in how to do it well, and equipping the health services sector so that appropriate monitoring and improvement in practice occurs. So I see it as a great step forward in what is really quite a challenging area.
We're dealing with best practice. Sometimes these things feel like they need a lot of time, but Eddie, you're often dealing with these quite quickly and there's often uncertainty around diagnosis.
Oh, absolutely. And when someone first presents to a healthcare facility, it can be really difficult to work out what's going on. And that's some of the other importance of some of these clinical care standards is around the transfer of that information as well across the care settings. So you're not seeing someone for the first time when they pitch up in the emergency department. You know what's happened to them, both in the immediate past, but also the more distant past. And this is key in understanding some of the responsive behaviours, especially in older people, is not just what's happening now, but what's happened in the lead up to these events as well.
So knowing people is really important. It allows us to have those non-pharmacological interventions, which we'll get to in a moment. But first, I'd love to share a story of James. James has an intellectual disability and he has mental health conditions. He works as an advocate for this Council for Intellectual Disability, and he's going to tell us about some of the strategies he uses to help him in his day-to-day life.
I was diagnosed with OCD, the traits of OCD, high mild depression and high anxiety. I have what's called a stress thermometer. Blue is the safe level. Yellow is frustrated, bit frustrated when services don't work with you and that. Orange is risky thoughts. You might think about doing something wrong. The red is out of control, where you're smashing places up. You're throwing yourself in front of traffic, even though you don't want to kill yourself. So what we do in the orange, we try and get me out of the orange because it's a risk. The orange will actually send me into the red. So once we get down to the yellow, we are at a level where we can talk about it, and that can bring me further down into the blue then. So what we do is we use my cats as support. Jo Asher, the support worker cat, she's registered to the NDIS. There's another cat that's registered called Fluffy. She's not here today. Kylie Singles, a church support worker. And then we have Yvette Proud, past CID participation manager. They're my companions, they're my friends, and they help me calm down and that.
James also told us about his behaviour support plan and how he was involved in developing it.
We need to put in that when I'm upset and that, I don't like staff to pursue me. I like to be left on my own. It was good having my say. And we also said that before staff work with me, They must be trained in my support plan. They must be trained. My support plan has words and it has also pictures of cats on them. It's reviewed by the behaviour support specialist. And then when the review comes on, I'm interviewed again. We have the opportunity to put new stuff on as they occur. There might be new stuff I had in my life, like new stress stuff and that wasn't on the original plan, that have to be put in.
As well as these non-medication strategies, James is also taking psychotropic medicines, which he feels are an important part of his care. He told us how he and his psychiatrist work together.
She works for people with a disability. She also works with my support people, and she's fair in her decisions. She explains the decision. She doesn't say you got to take that and that's it. She explained why she's put me on it, and then she tells me how I can apply for a review if it's not working. And those reviews are normally conducted 3 monthly, unless the NDIS asks for an earlier review, which I had put. She said, we've increased your medication. So she does an assessment on the table. Then she weighs that up in her decision making. And she said, we don't want you to go back to jail. So she weighs that part up too. We're on the same side now, and we are working as a team.
It was so great seeing you all nodding furiously throughout that. Julian, can you give us an example of, well, that was a great example, but how non-medication strategies can be so effective in the disability space?
I really thank James for sharing his personal experience and expertise. It was really clear that the example he shared taught us a lot about how we keep people at the centre of the conversation around decision making in their support, whether that's around the behaviour support plan and its implementation, or around decision making in psychotropic prescribing. That's really what I liked and was a take-home message for me.
Yeah. Eddie, what about in aged care?
Yeah, look, I think one of the really interesting things that brought out to me was the importance that when we think about behavioural support plans, we're actually thinking about the individual that plan applies to rather than the behaviour itself. And I always think, you know, if you've known one person with dementia, you've known one person with dementia, and their lifetime experience, even what looks like a similar behaviour is very different to that individual. And so it's important to look at not just how you manage, say, a particular behaviour, but what it means to that person. What have they found has worked? What have their care partners found has worked? And how we communicate that information across the whole care setting.
So one particular care setting that is challenging is something like an emergency department, Carolyn. How would you implement something like this there?
Oh, we find it really useful when a person comes into the emergency department with their behaviour support plan, because I can read through that plan and understand, you know, what are the things that are important to them. What do their behaviours mean? Like sometimes it might be that when they behave in that way, that might be that they're in pain. So I think that I can use that to incorporate that into the care of the person. It's not my job in the emergency department. I've never seen that person before, so it's not my role to write a behaviour support plan, but I think it's really my role to understand and be thoughtful about the behaviour support plan.
Yeah, and sort of what goes into that initial assessment?
When you see someone in the emergency department?
Well, with the behaviours, if you're trying to find your way towards a non-medical approach, how do you actually get to that?
I think it's being kind and thoughtful and open when you see a person and listen to them. And I think give them the benefit of the doubt. I think the vast majority of people we see are amazing and beautiful people. And if we go into an encounter with that in mind, then we can have a different outcome, I think.
So we're talking a lot about non-medications here, but Juanita, of course, sometimes they are necessary. Talk to me through how that decision should be made.
I think that James actually in that video showed he was an integral part of the whole decision-making process, and he was very aware of his behaviour support plan. The way he explained his levels was really simple and clear. But, you know, sometimes, as he said, he needs his medicines and they helped him de-stress. But I think it was really important that he worked with his psychiatrist to sort of work out what worked with him, and the medication was regularly reviewed. And you know that the non-pharmacological strategies didn't stop; they weren't used. You know, the medicine wasn't used instead of it; it was all sort of integrated and used together.
Julian, how does that gel with your experience?
Very well. I think we need quite a sophisticated approach to assessing and managing behaviours of concern. The first important principle, I think, and it touches on something Carolyn was saying about the emergency department context, is when someone presents, we need to understand what's usual for the person, understand their baseline. And the behaviour support plan and other sources of information really tell us a lot about that baseline for the person. We mustn't make assumptions or go into that situation with a bias that predetermines an outcome related to behaviour, but understand whether that behaviour is new onset or escalating from baseline, and then really undertake a significant assessment of that behaviour from a medical, from a psychiatric perspective, from an environmental perspective, to understand the contributions before we conclude the nature of that behaviour disturbance and what we should do. But often, as Juanita was saying, there is really a blended approach required.
Eddie, is it sort of about having that real clear reason or purpose for that prescription?
Yeah, and to appreciate the fact that you might be causing some of the issues as well. I think, you know, listening to those experiences within the ED department and with escalation, and, you know, if you had to design the perfect environment to create behaviours, then often an inpatient setting is that, with disorientation, with lighting, with noise, with sounds, with stimuli, that we may be actually making things worse rather than better. So some of the prescribing is knowing when to prescribe and also when not to prescribe. And actually it's more about environment than medications. And as Juanita said, the two things are not mutually exclusive. You know, you can utilise non-pharmacological management strategies at the same time as prescribing, and when you do prescribe, it's at the lowest level to get the effective intervention rather than going high and hard.
Because there are those places, especially when there's a safety issue. Carolyn?
Yeah, it's challenging in the ED. I think we're actually trained very carefully in how to manage violent and aggressive episodes. And often there's a call from the police or the ambulance, the person's on their way, the team gets together, we talk about the roles, and then you're, you know, confronted with this situation that's actually quite aggressive. People have got big uniforms on, lots of, you know, like it's quite a confronting situation for the staff as it is for the patient. So you're trying to come in and think, I suppose my role as the team leader often is to make everyone safe. So it's not just the patients and their carers, it's everyone in the emergency department, but also to really think through what's the cause. So I think sometimes we have to use psychotropic medicines just to control that situation so that everyone remains safe, with the idea that we can then be really systematic in the way we're assessing that person looking for a medical cause. And sometimes it's quite simple. I can give an anecdotal story, but there was a call at the hospital where I work in a small hospital, and the police rang saying that there's someone who's aggressive in the street. The ambulance and the police were coming in together, and this person arrived, and it was a small person with Down syndrome, and I just said to and we'd all prepared for this situation. We were going to sedate this person as soon as they arrived, and I said, look, can everyone just stand back a bit? And the nurse and the junior doctor and I, we sat and spoke to the patient, and I just said to the patient, we didn't have their family, we didn't have their carer, we hadn't seen the person before. So I suppose I said to the junior doctor, we just need to start from the head to the toe, and we've got a delirium pathway that we use. And the person they couldn't pass urine. They had 1,000 mils in their bladder. Oh. So I said to the man, we really need to put a catheter in. We put the catheter in, didn't use any medication. And he said, "Can I have a sandwich, please?" And I was like, yeah. So I think because he couldn't communicate clearly enough to the police and the ambulance and the aggressive situation we're in, it would have been very easy to have sedated that man. But I think by standing back and trying to de-escalate the situation and then think about the person, we were able to manage their urinary retention without drugs. Mm. And speaking to the care workers, his behaviour had been escalating over a few months, and they were thinking about, has he got dementia? Because people with Down syndrome do get dementia at a younger age. But I suspect he'd been having urinary retention for months, and that no one had actually realised until this incident in the street. And so in some ways it was good that he got brought to the emergency department. We worked out what was going on, but it could have been a very different situation.
Yeah, it's like what you were saying before, slowing down, having that compassion. Of course, there are certain situations, as you all mentioned, about where there are acute situations where those are prescribed. So we need to talk us through reviews and coming back and revisiting those prescriptions.
I think, in the acute situation, obviously you need to, I suppose, get someone to a level of functioning where, their behaviours are settled. But what someone needs at one point isn't necessarily what they need for the next 3 months or the next year. And we do know that a lot of people, especially in aged care, but also in people with disability, stay on medications at high doses for an extended period of time. So I don't think that often these medications are started, really randomly, but often they're not reviewed perhaps as often as they should have. And that's what the standard does. It really encourages regular review. I think we don't actually give a figure, but usually it's about every 3 months as a minimum, and just sort of ask the questions, do we need, could we just use a little bit less and see how this particular person goes? With the view to, as I think you were saying, is using the minimal amount for the shortest possible time.
So coming to this idea of reviews and also people understanding what they're being prescribed, I want to show you a video from Bronte. Bronte is a passionate advocate for dementia care, and he was involved in developing the standard. He cared for Glenda, his loving wife of 41 years and devoted mother of their 2 sons, after she was diagnosed with a rare form of early onset dementia.
Glenda was a well-known and well-regarded educator, had been a high academic achiever all of her life. She was diagnosed at the age of 56. Her disease is called the visual variant of Alzheimer's disease. So she had an inability, progressive inability to recognise everyday things, it's called functional blindness. By about the 9th and 10th year of her living here at home, when her behaviours became, let's say they were bordering towards what's known as the psychotic behaviours. 2 psychotropics, one after the other, prescribed there. The first one was lorazepam, and then the second one, but only in the last 2 months of her remaining at home, was quetiapine. She was only on that for several months, but in that short time is when the side effects became very obvious, having muscular movement disorders, and that eventually led to a very serious fall where she was then had to be hospitalised. The consulting specialist there said that this was a very extreme reaction to this particular psychotropic. So his action was to de-prescribe that medication and to wean her off that over a period of a month or so.
We asked Bronte his thoughts about informed consent.
I consented at the time. It wasn't a question that was put to us as such, however. It was an inferred or implied position. There was basic, minimal information given. The side effects or the harms were not pointed out at all. And I took it at face value that he was doing it in Glenda's best interests. The standard, as detailed as it is, I think will ultimately provide better quality care for those living with dementia. However, I think certainly you need to have access to more information about the risks and the benefits and to weigh those things up.
Bronte told us how non-medication strategies were used to support Glenda.
There are alternatives for medication. You can have non-pharmacological interventions that require deeper understanding of each individual person living with dementia, so that a workable, usable, practical behavioural support plan can be written up and implemented. She was unable to engage in very much else other than have oral input, which, and as a person who loved music and sang in a choir, this was the only non-pharmacological intervention that any of us could come up with, that she listened to music all the time. So she had this kind of music therapy, if you like. So this formed the basis of what is now known as a behavioural support plan. It's not to say that these medications shouldn't be used at all, but as a first resort, it should be a non-pharmacological intervention for difficult behaviours or challenging behaviours that emerge over time with people with dementia. Just because you've got dementia doesn't mean that you can't still have the best life possible.
So that was really about informed consent, and I'm curious to hear from each of you about what that looks like in your clinical setting. Eddie, we'll start with you.
Yeah, well, I would always try and have that dynamic conversation with someone. I think it's always important to recognise when we're talking about prescribing any medication, really, that any drug with an effect has potential side effects. And, you know, the balance between the effect you're going for and the side effects which are going to impact on quality of life is a dynamic relationship and does change according to the seriousness of the condition and the need for urgent treatment. So I think having that open and honest discussion on those potential side effects and also the potential benefits early on is absolutely key. I mean, we know, for example, with antipsychotic medications, if you treat 1,000 people for 12 weeks with change behaviours with an antipsychotic, yes, you'll get an improvement in 100 to 150 of them, but along the way, you'll cause 18 strokes and 10 heart attacks, and 80 to 120 of them will have a fall. So, it's not that you're not getting an effect, it's how you balance those side effects and making sure, as we heard in the presentation, that you actually consent someone to what those side effects are rather than in vague and nebulous terms.
Julian, how about your clinical setting?
My area is working with people with intellectual and developmental disabilities, and there we see people experience a range of physical health conditions in addition to mental health concerns. So the risks associated with prescribing are higher than for the general population. Here, I think an important principle is keeping the person at the centre in decision-making and consent, and assuming that the person has the capacity to consent, and undertaking a decision-specific capacity assessment around the decision-making in medication is really important. Obviously, for some people, particularly those with very severe levels of intellectual disability, so those with lower levels of cognitive ability, they may require support in decision-making. And for some people, they may require someone else to be in the driving seat in decision-making. But that still means that that person in the driving seat must be fully briefed around the risks and benefits of medication use in that context. And so there's a big responsibility prescribers have in that area.
Carolyn?
It's challenging in the ED. I think we don't know the person, we don't know their context. And as I said, we're thinking about safety of everyone as well. So I think that we're doing our best, and sometimes, and I think as Juanita referred to, we're often using the drugs as a once-off rather than as a continuing medication. But for us, it's controlling the situation so that it can be safe. We do our best to get informed consent, and we should always do that. And we should always be trying to contact the person's family and understanding what's going on. But sometimes we have to give people psychotropics without consent, but that should be a rarity rather than a common occurrence.
Juanita?
I think also that the informed consent process shouldn't just be about the benefits and the risks. It's about the plan. You know, we're going to monitor, we're going to see whether they work. We're not going to use them forever. If there are side effects, we hope we can pick them up, like Bronte was saying, and then, you know, either change the medication or reduce the medication, and really always sort of think about non-pharmacological ways of managing behaviours first. Yeah.
Julian, you look like you've got something to say.
If I could just also jump in, I think there are some adjustments we can make in the consent process that really mean that informed consent is possible in many situations where people at first assume that it's just not possible. If we're aware of the impacts of the cognitive disability on the person and how they're normally engaged in decision making, and what adjustments need to be made to support their decision making capacity, we can make major inroads and involve the person more.
Listening to all of you speaking, it sounds so sensible, and I'm sure that the people who are watching are going, yeah, like, this is my space, I'm good at this. What does the clinical care standard add to support people, Eddie?
Look, I think one of the key things it brings is that communication across all levels of care. I mean, we see in hospital people for a tiny window of their life. You know, most of their life is spent at home, be that in the community at large or in a residential care home. And we're very poor, I think, at communicating information across care transitions. And I think the emphasis on making sure that care plans, behavioural support plans, prescribing and deprescribing plans move across with the person living with dementia or cognitive disability, rather than just being sort of separate episodes of care, but looking at that continuum of care and the continuum of planning is something that this really brings to the table for the first time.
Well, I mean, the clinical care standard speaks for itself, but hopefully this has given a bit more context around it for people and just shown how useful it can be. Thank you all for your time and your insights. And we're going to hear now from Professor Christine Kilpatrick, who is the chair of the board of the Australian Commission on Safety and Quality in Healthcare, who will officially launch the standard.
I'd like to thank you all for being here today to discuss this important and complex topic. The Commission has long had an interest in improving the safety and quality of care for people with cognitive impairment and in reducing the risks associated with psychotropic medicines, and this standard adds significantly to that body of work. The standard has been developed in consultation with clinicians, consumer advocates and researchers with expertise and experience in the areas of aged care and disability. The Commission is grateful for their advice about how to provide best practice care and uphold the human rights and dignity of people with cognitive disability or impairment. Whilst it is important to reduce the inappropriate use of psychotropic medicines, we must also recognise that these medicines often play a very important role in people's health care. Even when psychotropic medicines are an appropriate choice, we can do much to ensure their safe use, as has been outlined so clearly in the standard. Achieving improvements in care is not the job of one clinician or service, but requires a coordinated approach amongst healthcare workers and across the community. I'm therefore pleased to acknowledge the support and endorsement of the Aged Care Safety and Quality Commission and the NDIS Quality and Safeguards Commission in developing this standard. Working together, our three commissions can do much to ensure a consistent approach for people with cognitive disability and impairment, and to support their human rights, dignity and quality of life wherever they are in their life or healthcare journey. I would like to thank Bronte and James for sharing their experiences, our panel, and all the consumers and clinical experts involved in the development of this national standard. Finally, thank you for taking the time to join us, and I hope that you have enjoyed this webcast, and I'm pleased to commend this standard to you.
Thank you, Professor Kilpatrick. And I'd also like to thank our panellists, Bronte and James, and you, our audience, for joining us today. I hope you found this helpful as an introduction to the new standard. You'll find more information on the new psychotropic medicines in cognitive disability or impairment clinical care standard on the Commission's website. You'll also find links to a range of resources for consumers, clinicians, and healthcare services, including an easy read version of the standard. Please tell your colleagues about this new standard and share this webcast widely. I'm Tegan Taylor. Thank you again for joining us.